So I give you the key points of my talk to start with. First, these are my disclosures. And WHO has set the goal to eliminate hepatitis C by 2030. And that means diagnosing 90%, treat coverage 80%, and reduction of deaths. But by 2017, only 12 countries were on track to reach these goals. And there are many barriers for elimination, like awareness of the infection, economy for testing, and also by reducing the burden depends on the successful of prevention and outreach, screening, and treatment, and maybe also progress in key countries with high burden like China, India, and Afghanistan. These are the goals. We should stop 90% of new cases. We should treat 80%. And we should reduce the deaths by 65%. This is not easy, and you can see that we are long from doing this here. This was in 2016. You can see that not many patients were treated if we should reach these goals. These were the countries which were on track to reach these goals, and the first one to do that, you saw as Stefan just talked about, was Iceland. I think they did this year. You can see that we had 1.75 million new infections per year at that time point. And we had 71 million. I'm not sure that the figure is correct because they reduced it from 170 to 71 million in just 1 year. And I'm not so sure that we really know, but you can see in the Eastern Mediterranean and Western Pacific and in the European region, and particularly in the Eastern, we have very high numbers. So what is needed for elimination, and where are the patients? And you see, I think we would have to find new cases, and also the old cases. We have to upscale treatment. We have to treat everybody, and also marginalized groups, and in new settings where we can reach these groups. And that means we have to have other providers, and we have to link it to care, and we have to have prevention, and it has to be affordable. Let's have a look on these things. But we just need to simplify this treatment. Test them easy, on the spot, treat them when we have the results and confirm that they are cured. So the strategy would be to give HPV treatment without any restrictions, like fibrosis stage. We have to treat these marginalized groups like PVIDs and MSMs, and we have retreat those who have failures for treatment. And we have to wide-scale prevention programs like NEP and OST, and of course also safe medical procedures. Not everywhere all blood units are tested, and not everywhere we have disposable syringes and needles. If we start to look a little on these finding new cases and kind of upscale of treatment, first of all, this is a study where they went out and asked people in different parts of the world whether they were aware of the good treatments that are at hand for hepatitis C, and you can see the awareness was not very good. Then we have to decide what kind of strategy we should use for screening, and it's obvious that we should use high-risk groups like PVID and MSM. And in US, they also screen baby boomers, those who are born 45 to 65. But you can see in Europe, this maybe will not be the correct years to do that, because you've seen differences where you have the peak of prevalence of hepatitis C. It's different between the different countries here. You can also go for population-based screening, and this is a publication in 2018 from France, where they assessed the cost-effectiveness of hepatitis C screening in France. And they found that universal screening was the most effective strategy, and it was also cost-effective where they initiated treatment straight away, of course dependent on the pricing. And then in 2016-17, there was a collaborative effort here and publication from the European states. And you can see here that they really said we need to have a quite large expansion of screening programs to reach the WHO goals. But at that time point, we had 3.2 million cases, but only 1/3 was diagnosed with viremia, and only 4 to 6% were treated. So that was a very low number, I would say. And here you can see that the highest incidence is in the Eastern Europe, and there are many places where we don't have very good statistics. And you can see here that from having a viremic infection, to get treatment, you miss very many patients. But as we have these fantastically good now pangenotypic new drugs, you had an increase in the number treated in Europe, and it came with the new drugs here. You can see that. And that changed the situation. And with this, if we can follow up the goals, we maybe can diminish the outcome of viremic infections, of liver-related deaths, hepatocellular carcinoma, and decompensated cirrhosis. The road to elimination here was also analyzed 2017 in 91 countries. And they found that during 2017, we only reduced the burden by 0.7%. And there were very few countries on the target to achieve these very ambitious goals that the WHO has set up. And you can see that they estimated that you needed to have more than 7% of your population with HCV you needed to treat those many to reach these goals. And you can see these are the countries that had that. Small countries like Iceland is not there because they are ahead, but you can see in Australia there were 16% treated, and in Germany 7% of those infected. But this is a bit a tricky thing. Here you can see the net cure rate, meaning you have treated that many patients and you deduct the number who got new infections. And you can see here, for instance, in Russia, you had an increase in the number of infections. And all these are red are increased number of infections that year. So, but these countries had a diminishing prevalence of infection due to treatment. If we take a very large country like China, this publication came in 2019, and they made here they looked on what will happen. If you do nothing, you see you have nearly 10 million here, infected patients. If you do nothing, you will come up to, in 2050, nearly 30 million people. If you use the treatment they've done in the pre-DIA scenario, maybe a little less, but they will still have an increasing number. It's only if you treat with DIAs and you have no restrictions, you can treat all patients, not only those most advanced cirrhosis and advanced fibrosis. That's the only way you can come down with a number in China. And in this publication by Wu in 2019, if you allow treatment to all by 2021, you will have a peak in 2020 with 10.75 million infected, and it will decrease to 7.9 by 2050. And if this should be stopped in a way, they have to expand screening, they have to launch DIA, and use rapidly expanded number of treated patients. Otherwise, it will not be achieved. Let's have a look also at what kind of patients we treat, whether it is all patients, not only cirrhotic patients, and if we can treat marginalized populations and in new settings where we reach them better, and if we can provide it to other than specialists. Let's have a look on these things, and you can see in the European Union, it was only until 2018 that we were allowed, all countries were allowed to treat without restrictions for fibrosis. In Sweden, we had restrictions, only treat F2 and more, up till 2 years ago. The thing is that we have used to have centralized testing and centralized treatment in clinics where specialists are, but we will not reach many marginalized patients. So we need a decentralized service where we have it in prisons, community health centers, and mobile, maybe mobile services where many are starting up. And we have it in NSP services and in sexual health clinics and so forth, and maybe also in shelters. This is an example where they have come a very long way, and this is from Australia, and you have the prescriptions per month for hepatitis C, and you can see that it came from specialists, which had a huge bulk of patients when you get back to 2016. But now, these days, the other physicians and general practitioners are those who prescribe most of the drugs. So they have decentralized the treatment quite substantially. And this has made an impact on the prevalence in this population, which has come down before the DIA. You see a lot more patients had viremic hepatitis C, and now it has decreased. So the prevalence has decreased by this. Stefan alluded to the program in Iceland, which is a small circumscribed country with very few patients. They had some 808 to 1,300 patients, and already after 1 year, they had treated half of their population. And I guess they have treated all now. So they will be first to reach the WHO goals. But decentralized care can also be done in countries where middle income and maybe also in low income countries. And this is an example from India, where they have treated nearly 50,000 patients. And they have decentralized care with DIA. And it was regarded as safe, regardless of genotype, presence of cirrhosis. This is the program we have in Stockholm for marginalized people. You can see that most of the work is done by nurses. All in blue here is done by nurses. It's only this in red who is done by the doctors, who generally only prescribe the drug, and then the nurses make all the other things. And this is maybe a setting where we have patients, which was the first category that Stefan talked about. And we have a hepatitis phone for those, because they nearly all have cell phones. And they can call the nurse and say, you should come because your medicine is now running out. Says who? Say, your nurse at the Neptune clinic. Okay, and then they come. So we can treat these patients. And here you can see one example with an advanced disease. He's 55 years. He's injecting amphetamine, and he has a fibrosis stage 4. And he has a very highly risk behavior here. This is the risk behavior and the frequency of risk behavior. This is how he changes needles. And you see his risk behavior come down. Then he gets treatment, and he clears the virus. And you can see over time that the risk behavior in this clinic has come down over time, which is very important. It's important to have this risk down. And he has no housing, so he has a do-not pill box where he has 1 day, he has 7 days treatment in this pill box. And then he's called from a nurse and gets back and gets a new treatment for next week. Let's also look a little on linkage to care and prevention and affordable treatment. And this is the cascade of treatment which need to be. You need to have prevention, testing, linkage, treatment, and follow-up of that. And we are all aware of these things. And one method of doing this very early on was the ECHO model, which was used in US, in southern states. And people needed much easier access to the specialist care, and there were not enough specialists. So this referred to the primary care physicians, which could call a specialist. And now we have treatment with nurses. And this is also a possibility. It's to integrate it to HIV programs, which are launched in many countries. This is in India, where they have launched HCV testing in the program of HIV. And you can see what they achieved was that integration of HIV testing with HIV harm reduction services, it increased the uptake of HIV among PVIDs. And this intervention versus usual care was very much better. Still, their awareness is not very good. You can see here that in this intervention care, you can see that the awareness came up by 30%, but it was very, very low in other settings. So this is a lot. We have a lot to work with there. Here you can see on a worldwide basis the importance of PVIDs, and drug use for spread. On a global basis, they say 38%. It's much higher, of course, in Western Europe and in the United States versus in low and middle-income countries where maybe safe procedures is more important. But you can see here that if you should go with this PVIDs, you need both opiate substitution therapy in combination with needle exchange programs. And then you can reduce the risk for reinfections quite substantially. This I got from Professor Dillon, and it says if you treat one patient who has who shares the needles with one, you have a 200% sustained viral response rate. But if you treat one patient, you have a lot of patients they share needles with, you might have 8,100% sustained viral response rate. And it looks fine. Still, as I started out to say, there were only these 12 countries which were on track. But that was a few years ago. But you can see here that on an average, countries who had an increase in the number is Sub-Saharan Africa, is Eastern Europe, like Russia, whereas the countries who were on track, they treated 5 more for everyone which got a new infection. And this was at the last EASL meeting, there were a report here which countries which were on track to reach the elimination by 2030, and those are the countries here in green. I learned now that's a new publication in Liver International, which just came out on the web. It will be in paper soon. And then Italy and North Korea and Switzerland also came in the green sector. That's very reassuring. But you see the majority of countries, even high-income countries, they have a long time to get this, and they will not reach this goal by 2030. I think maybe we'll do that in Sweden. We were in the red sector, that's 2050, but we now treat 3 to 4 times more than we have new cases, and we have treated at least 1/3 of all cases. So I believe we will do it before 2030. But 84% of high-income countries are not on track to meet the WHO 2030 targets, and that's really something to think about. And to reach that, we need a better awareness of the HIV status and prevention from new infections. We need access to testing on a very easy way, on spot, on the place, outside the hospitals, and we need linkage to care. And we need access to DIA treatment decentralized in those spots. And we need development of national plans. Not all countries have a national plan. And to improve this, you can see here, this is the publication in Liver International, which was updated. And you can see we need to do all these things. Otherwise, we will not reach the goals. And you're all familiar with that. And to do that, we need collaboration with all stakeholders. It's very essential. We need a collaboration with healthcare personnel, national governments, patients and civil society, and pharma. Pharma is doing what it can, providing opportunity to treat generic drugs more cheap. And we need global organization. Otherwise, we will never reach it. And I think that we have to be realistic that it is a certain number of countries who will reach the goal, but many will have a long way to go. Thank you.